This is the Healthcare Marketplace Specialization, Healthcare Marketplace Overview. My name is Steve Parenti, and this is Module 1.2.3, Market Evolution, Healthcare Cost Growth. Here's a pretty revealing graph on healthcare expenditure going on in the United States today. We're looking at a trend from 1990 and then projections out through 2022. If we look at, first of all, the purple line, the share of gross domestic product, 1990 we're talking about 12% of GDP. By 2012 we're estimated to be 17.6%. In 2023 we're at 19.3%. If we drew a line about right now, the thought is we're somewhere maybe at about 18% or so. That's barely at 18, isn't it? 18. And so if you look at, are there moments where we're actually doing better than not? National health expenditure growth, the blue line, basically averages about 5.7%. When we look at what overall GDP growth is in the same period of time, it's a little less than that. Now, this is actually a pretty, healthcare costs are going up pretty dramatically, but things are really out of whack in 1990. They become less out of whack here. And actually there's a moment where healthcare costs actually are doing sometimes better than where the economy is. But when the economy takes a hit, basically what you see is the trends also fall here as well. We do think that there's going to be a lot more alignment going forward in the better part of the 20-teens, if you will. But time will tell. Right now, the expectation is that healthcare expenditure growth will grow faster, and that's about where we're seeing right now, and then pretty much stay faster over a period of time with an aging population. So what drives expenditure? My training is in health economics, and so I think about it this way. There's a supply side and a demand side. So on the supply side, these are what the physicians would do, the hospitals would do. Demand side is really what the consumers are going to do, what consumers have to think about. On the supply side, there's the issue of imperfect information. There's also the thought of increasing monopoly rights that providers have in this space. There's the concern that there's really not a lot of information on quality of care, and so we basically try to compensate for that by having better and newer technologies, hoping that that will improve what's going on. And then finally, technological change. There's always something new that's out in the market, in part driven by the imperfect information and quality pieces that are out there. On the demand side, we have insurance that is available to the majority of Americans. We might say that the nation does not have a national health insurance program, and we do have uninsured, but the majority of folks have insurance. And after the Affordable Care Act, 90% of the U.S. has some form of health insurance. And a good chunk of that gets tax advantaged, as we talk about in the previous modules. And as a result of that, the thought is that basically lowers the effective price of insurance and actually the price of medical care, so that people want to demand more of it. Aging population, as people age, they really need more medical care because things are breaking on them. Basically, no one lives forever, and the warranty does wear out over a period of time. We as a society prefer technology. We very rarely don't want to sit and just watch a lot of watchful waiting. We are kind of an interventionist type of society for most medical technologies, and we have behaviors that basically are expensive. We eat too much, and that costs money in terms of additional problems for diabetes and other parts of the healthcare system, and then tobacco use is another problem as well. So what do we do to control these costs? We try to limit hospital inputs. We try to not let hospitals buy things. That's what certificate of need laws were about, though a lot of them got repealed by the Reagan administration in the 1990s. We have insurance companies have this tool called utilization management. Employers use it too, where you need to have pre-authorization to get an advanced medical procedure. People don't like that because they're being told no. It's essentially an implicit form of rationing by use of a service, but that's one way that you can control costs. Another way that's price rationing is rate setting. That's essentially where the government or an insurer says, this is how much we're going to pay, and that's it. And that potentially is a way to keep costs down, because price times quantity does ultimately give us expenditure. Prospective payment, we mentioned before, this DRG stands for Diagnosis Related Groups. There's a running joke from a really famous health economist, Uwe Reinhardt, at Princeton University. You'll see his work in the New York Times quite a bit, where Uwe said in 1990 that the real reason why the Soviet Union basically gave up on the Cold War was that once they saw that the United States, particularly Reagan, could implement DRGs in 1983 as a cost control measure, they knew that they could never compete with a socialist country as socialist as the United States. And there's something true about that. They basically govern a good chunk of the health economy, and then were picked up by private insurers as another means as well. And what they basically did was say, we're only going to pay per admission. We're not going to pay you by day anymore, hospitals. And that changed the world dramatically for hospitals' finances. And then managed care. The idea of saying that there has to be a gatekeeper, there needs to be a primary care physician assigned to you. You can't just get whatever care you want. And the thought being that if care was managed by a primary care physician or an insurance company, that will control costs. This concludes this module on healthcare cost expenditures.